it was clear that poverty was making people sick. And so we actually started with our staff during Anti-Poverty Week to do more advocacy around the fact that poverty makes us sick. And this should make us sick as a society. We need to do something about this. So that work really took off with our intersectoral partners. There was an understanding that if poverty was this big factor that was um, causing so many of our health problems, and it was also causing problems with lower rates of education and unemployment and other factors, maybe collaboratively we should be partnering more to not just always put that into the parking lot of an issue that's complex and we'll deal with it later. Maybe that should be the main thing we work on together. And so that was really the genesis for getting the Saskatoon Poverty Reduction Partnership going. And they then asked us to do more research into what could be done about this. Are there actual programs and policies that can turn those social determinants of health around and reduce poverty, but also through reducing rates of high unemployment and improve education rates? And the predominant factor that came out was poverty. We happen to have racialized poverty in this province, and especially in Saskatoon. And so it was at that point that we started looking at the intersection between poverty and racism and institutionalized racism, and the need to actually go at these things simultaneously.
I remember like reading through it and thinking, how is this even possible? How is it that we have the highest HIV rates? How is it that we have marginalization and oppression to the degree to which it was existing in 2008? And what is our role moving forward from a collaborative community practice to move those outcomes and to improve the health and well-being for all people? Because those pieces around disparity aren't good for anybody. I mean, they're particularly horrible for people who are marginalized and oppressed, but they're also really bad for the city as a whole. And so I wanted to be part of creating some kind of network that would address those disparity outcomes with a collaborative approach to talking very specifically around why we need to address poverty, as opposed to very specific aspects or specific social determinants of health, or like it's not just a food security issue. We need to talk about how all the pieces of those outcomes are interconnected, complex, and also individualized, even though it needs to be a more holistic approach to the way that we talk about them.
You have to remember that a couple of decades ago when this started, it was known that poverty causes ill health in lots of parts of the world, but it seems like unless you see it in your own neighborhood, in your own backyard, there's a tendency to say, oh, but not here, surely. You know, we have universal programs and, you know, we're not showing discrimination, and things certainly wouldn't be the same here. So what we saw is that, yeah, not only are we seeing it here too, but quite frankly, in Western Canada and many of our cities, that disparity is actually worse than other parts of Canada. So it forces us to look differently. I think the other issue is you don't even recognize, if you don't have the data, you don't know where to focus quality improvement. So you design one size fits all programs, or, you know, as much as you can to take into account your experience, and even in a patient-centered approach, it depends on which patients you bring in. But if you stratify your data in a way that you get this constant stream of quality metrics on subpopulations, you can't make assumptions and you can't hide from the disparities that are there. And we found as we do this systematically in quality improvement within healthcare, you're sometimes surprised by which subgroups aren't getting the same access or outcomes. It's not always the ones that you would think would be obvious. But then you design something to change that. And unless you're monitoring it, you don't know if the thing you designed is actually having a desired impact or not. So we need to build it in as a continuous quality improvement initiative within healthcare. And then I'd say on the intersectoral side, the reason we need this research is that people tend to have a fatalistic approach that poverty is always here and it's always with us, or there's an assumption that this is a value judgment issue, or uh, you know, people are just bearing the fruits of how they lived or something. And yes, there's always some elements of personal choice, but there is this failure to recognize that, in fact, many of these determinants build upon one another and it limits choices. And in order to give people equal chances to succeed, and you need to actually change policies, taking more of a health and all policies approach. So we found that this research has also shown that poverty, doing nothing, poverty does cost. And in fact, there are ways to change our programs and policies in a way that is both more cost effective and meets the needs of individuals more within society. So it's win-win.